link, Dr. Nina?
Just fine.
Thank you. Thank you. Good evening, everyone. It's a warm welcome to each one of you as we kick off the 14th series of our ISAR Catalyst webinar, and it's truly a pleasure to see many esteemed IVF and gynecology experts from across India gather here on this platform. So you are the catalyst in the field of reproductive health, making invaluable contribution and innovation in medical treatments, and that is the transforming lives nationwide. We at UNS, we take a pride in the being of highest and fastest growing nutraceutical companies, and we are committed to making a significant impact on people's lives through our high quality products. Our infertility portfolio, which includes brand like CoQ 300, CoQ LC, CoQ Port, CoQ Man, CoQ Fem. It's designed to empower individuals on their journey of to parenthood. So now it's my honor to invite all the all the dignitaries, all the faculties. No, from UNS, I request Shruti. She's a coordinator. From the medical department. She's going to introduce today's distinguished speakers as well as set the context of our discussion. So over to you, Ms. Shruti.
Thank you so much, Nakul sir. So good evening to all the esteemed faculty members for joining us today. We welcome you to the 14th series of the ISAR Fertility Catalyst webinar. The theme is all about infertility, and we are truly honored to have all of you us with here today. Today's chief guest is Dr. Rishma Pai ma'am, and guest of honor is Dr. Neena Malhotra ma'am. Thank you so much ma'am for your blessings and for being with here today. All of this would haven't been possible without the support and guidance of Dr. Amit Patki sir and Dr. Asha Bakshi ma'am, and obviously without the support and guidance of Dr. Anu ma'am and Dr. Fessy Lewis sir. Dr. Anu ma'am is the director at Vansh Fertility and Test Tube Baby Center, Ayushman Hospital.
Shruti,
Yes, ma'am.
I'll leave this part, yes.
Okay.
Because everybody it, yes.
Okay, ma'am. So with that, I would like to hand over to you, Dr. Anu ma'am. Then.
Yeah. Thank you, Shruti. So, good evening to all the esteemed doctors present here. It's a pleasure to welcome you all on this wonderful platform of ISAR Fertility Catalyst series. Today, we are doing our 14th webinar. So, it's a great milestone for all of us, and I'm really thankful to ISAR President Dr. Amit Patki sir and Secretary Dr. Asha Bakshi madam. Without their support, it would have not been possible. So without wasting time, since Amit Patki sir is not here, he's not able to join. So I would invite our vibrant secretary, ISAR Secretary Asha Bakshi madam, to share her pearls of wisdom. Asha Bakshi madam.
Thank you very much, Shruti, for the kind introduction. And first of all, I would like to congratulate you for this successful series of ISAR Catalyst program. And you and Dr. Fessy Lewis, you both are really doing excellent job. And every time you select good topics which are useful to most of the infertility specialists. And today, this whole program seems to be really star-studded, along with Dr. Amit Patki, Dr. Rishma Pai, and Dr. Neena Malhotra. They are really stars in themselves, and it is a really great thing that they are here. And the talk by Dr. Mugdha, I think no one else can be better than her, who is such an expert in recurrent implantation failure and recurrent pregnancy loss. So I'm sure we'll learn lots from her. And then Dr. Kunju Moidin will be telling us when to touch the adnexa and when not to touch, which is very, very important. And I think very important to learn when not to touch. And then Dr. Shivani will be talking about interesting cases. And from that, we will have lots of practical tips. So keep doing good work. And thank you very much for inviting me. And these programs really keep everyone on toes. So thank you very much once more. Bye.
Thank you once again. For this guidance and giving insight, and almost all the month you are guiding us and giving your pearls of wisdom. Over to you, Anu, to introduce our
Sorry.
Rishma. She will. Yes, Madam.
Hi, Rishma. Welcome.
Hi, sorry I'm running a little bit late,
No, no,
but
correct time,
happy to
correct.
join all of you.
Good evening, Rishma ma'am.
Good evening.
Good
Good
evening, Dr.
evening.
Rishma ma'am.
Good evening.
So, so today's chief guest is Dr. Rishma Dhillon. I think we all know her. Just kindly display ma'am's CV. Ma'am is our chief guest today. Yes. Yeah. Just a minute, please. Yeah. Ma'am is president-elect of IFFS, and she's former president FOXY, former president ISAR, IAGE, MOGS, and she's former president of MOGS, honorary FRCOG, fellowship honoris causa of Royal College of Obstetricians and Gynecologists, London, and she has numerous awards. She has won FIGO Women's Award 2023 Lifetime Achievement Award by Indian Society for Assisted Reproduction and by Indian Society for the Study of Reproduction and Fertility, ISSRF and TAPISAR, and Dr. Asthya Paul Lifetime Achievement Award by Indian Obstetrics and Gynecology Journal. And
That's okay. I think we can go ahead. Thank you.
Welcome,
Thank you
ma'am.
so much. Thank you. Thank you so much. Good evening to all of you. Thank you for giving me this honor and this privilege. It feels so special when our people call us and give us a little position of honor. Truly, it's been a wonderful, long journey to be here, having served in so many different capacities. And now I'm really happy and honored and proud that I can actually represent India on a bit of a global stage as the president-elect of the International Federation of Fertility Societies. And I really want, and my whole focus was on how we can take India on a more global platform in the fertility field. I know that for the European Society of Human Reproduction, for the American Society of Human Reproduction, lot of Indians attend those meetings and present their papers, but not very often that we get a platform to actually speak or to showcase the fabulous work that is being done by many of you present here. And so I hope that we can, manage to change that a little bit and give Indians the position and the honor that they actually so rightly deserve. So looking forward to that tenure. And in the meantime, Dr. Amit Patki, Dr. Asha, they're doing phenomenal work. I just messaged Dr. Amit Patki yesterday that what are you doing? How much are you all doing, to sort of spread the word of infertility everywhere. Fessy, of course, Anu, super hard workers, amazing. He's been telling me a couple of weeks, actually, Fessy, to join in, but it's just a very hectic phase of my life. But thank you so much, Fessy and Anu, for involving me in this. And I'm very happy actually to see today you have the experts in RPL here. And you have Mukta, who's really spent years doing all the RPL work and actually showing results. Many of our patients have been to them and have shown success. So that is wonderful. And what I actually liked the most was the last panel. A lot of young generation, Gen 2. I mean, we know all the parents, and now the second generation is all here with the eternally young Shivani actually moderating. So Shivani, you belong to that group only, Gen Next, and then all the younger people coming in. So it's great that ISAR is really giving a platform to all the young people to come up. They're so smart. I think they are way smarter than we were at their age. So it's great that they're getting the platform to, sort of showcase their skills and their knowledge. So all the very, very best to you. I think that the title itself is so catchy. I was very impressed. Fertility Catalyst. I think that's what all of us and ISAR is trying to do to really push forward the case for fertility. So thank you so much for having me here. All the very best to you. I believe a lot of successful such events have already happened. This is the 13th or 14th one, I think.
14th, madam, 14th.
14th, yeah.
14th.
So that's amazing. That already says and talks a lot about the success of this particular program. All the best, and here's wishing you the next 14 are equally successful. All the best. Thank you.
Thank you, madam. Thank you,
Thank you,
madam.
Rishma.
Thank you.
Thank you, madam, for coming in between busy schedule because no, we are honored for you being here and blessing us. Thank you, madam.
Good evening, Dr. Rishma. It was really
Thank you so much. Hi,
pleasure to
Tavis.
listen you.
Hi.
Very pleasant to listen you.
Thank you. Thank you.
Dr. Nina has joined, I think.
Dr. Anu ma'am, it's on mute.
Yeah. So Dr. Fessy, kindly invite a guest of honor.
Okay. We are equally honored to invite Dr. Nina Malhotra, our guest of honor, to say, I think she doesn't need an introduction, but she is the present Foxy Imaging Science Committee chairperson and also head of the Department of All India Institute of Medical Science, Delhi. And major achievements are Sir Malcolm Black Fellowship by RCOG in 2015, Overseas Fund of RCOG in 2010 and 2019, Imaging Science Award by the Foxy in 2006, CS Don Award by Foxy 3 times.
Stephen, skip all this.
Over to you, Dr. Nina.
A very good evening to all the viewers and my dear friends who are there on the virtual mode. Rishima, there's Dr. Asha, Fessy, and Anu, all of you. Thank you so very much. I think it's indeed an honor to share the platform with such celebrated academicians, including Fessy, Rishima, and who are all stalwarts, including Asha. I know Fessy is a very hardworking and an inspiring individual. And when he said, you have to come as a guest of honor, I could have never said no. I know all has been spoken. I guess this is my first time in seeing this program. I haven't been a part of it. But all I can hear, accolades coming for you, Fessy, and your team. And Anu, of course. I wish you all a good success, a good deliberations for this evening on such a pertinent topic. The speakers are all known in their field. I'm sure the deliberations will really be useful and productive to all those who have joined me. Thank you very much.
Thank you, Dr. Nina. And as you told, few of the previous 13 episodes are there in ISAR website. And if you type in YouTube, ISAR Catholic series, all the previous episodes is uploaded. So it will be great, revision for all the fellows and the postgraduates and those who are aspiring into the fertility. Thank you once again. Over to Dr. Anu.
Thank you, Nina ma'am, for your blessings. Thanks a lot. So we'll start our first session. The silent conversation from embryo, maternal crosstalk to cradle. And our speaker is Dr. Mugdha Roy. For this, I would like to invite the chairpersons, Dr. Sabita Dikshit. Dr. Sabita Dikshit, she's MBBS MS from Patna Medical College. And she's managing director at Dikshit IVF and Test Tube Baby Center, Prayagraj. And she is co-author of book Demystifying Endometriosis, member of ISAR, IFS, and ISOPOP. And she has won brand icon by Times Group and unsung hero by Foxy 2018. Welcome, Dr. Sabita. And our next chairperson is Dr. Gulpreet Bedi. Just a minute. Yeah. Madam is, she's director of Bedi Hospital, and she's running Bedi IVF since past 25 years. And she is trained in ultrasonography under Dr. Suresh from Chennai. She is a founder, president of ISAR Chandigarh chapter and a member of various societies. Welcome, Dr. Bedi. And our next chairperson is Dr. Santosh Gupta. She's senior consultant, reproductive medicine at Nova IVF Fertility, and she's joint secretary of Karnataka Society of Assisted Reproduction, and she's executive committee member of BISOP. Welcome, Dr. Santosh. So I request chairpersons to invite a speaker. It's
Anu, you.
Over to chairperson.
Okay.
Invite
So,
our speaker.
good evening, you all, and thanks for giving me this platform. I take great pleasure and honor to invite our speaker for today, Dr. Mugdha Raut. Dr. Mugdha Raut, we all know she is pioneer in immunology and recurrent pregnancy losses, and she's a managing director of the Dr. Raut Women Children Hospital, Mumbai. She has many affiliations. She education committee of American Society of Reproductive Medicine Immunology. She is member of the journal editorial board of Journal of Evidence Based Women's Health Society. Egypt, member of American and European Society of Reproductive Immunology, and she's member of MOGS, Foxy, and FIGO. And I think award list is very huge. She's a National Icon Year Award by Economic Times in Feb 2023. I'll mention few of them. Times of India Healthcare Achiever Award in 2018. She received Women of Impact Award Leadership Excellence Award among the Femina and the Cosmopolitan Top 10 Influential Women, Global Healthcare Achiever Award. And I think list goes on, but we all know she has achieved a lot in her field, and we are eager to hear you, Dr. Mugdha.
Thank you, Dr. Santosh.
Recording stopped.
For this kind introduction. And thank you all, especially Dr. Anu Agarwal, for this kind invitation. And thank you, Dr. Amit Patki, Dr. Rishma Pai, Dr. Asha Bakshi. Thank you all for this invitation. So just to begin with, just a minute. I'm Dr. Mugdha Raut, as you all know. I'm a gynecologist and a clinical reproductive immunologist. At Dr. Raut's Center for Reproductive Immunology.
Can you share the slides, please?
Yes, I'm sharing. Just a minute. The recording has stopped, right? Yes. So at Dr. Raut Center for Reproductive Immunology, along with my husband, Dr. Mohan Raut, we treat couples with repeated pregnancy loss, IVF failures, and unexplained infertility with reproductive immunology. And today, as a part of the ISAR Fertility Catalyst program, I'll be sharing insights on the silent conversation from the embryo maternal crosstalk to a cradle. You all generally transfer beautiful embryos every day. Everything is always fine. But what happens when even the best ones don't implant? Recently, or rather most of the times, when patients are referred to us, the gynecologist is also frustrated, the IVF specialist is frustrated, patient is frustrated. They've had multiple IVF failures, everything corrected, euploid embryos, beautiful blastocysts. Still, there's perfect timing and yet no implantation. And that's why today I'm so glad to be a part of the ISAR Fertility Catalyst program, because as a clinical reproductive immunologist, our role is to look beyond what's visible and identify the hidden barriers to success. Now, the paradox is, even when the embryo is perfect, implantation fails. And in such cases, the missing piece is often not the embryo, but the maternal immune system. So let us see what is the prognosis for a live birth after unexplained RIF following IVF or ICSI. According to a study by Kuth et al., surveying 118 patients with RIF found that only 49% of the respondents ultimately achieved a live birth in a 5.5-year follow-up period, which indicates that approximately 51% of RIF patients may not complete their family goals. So we must ask, is it always the embryo, or could the environment be responsible? Because even morphologically, perfect embryos sometimes fail. Even euploid embryos, which we consider gold standard, only help us to achieve around 40 to 50% success per transfer. So clearly, embryo quality alone does not explain every failure. So what do we do whenever there is failure? We investigate all known causes of RIF or RM, which are very similar. However, in 50 to 60% of such couples, all known causes are normal and the couples are handed over to nature. And this is exactly where clinical reproductive immunologists can make a difference. Instead of leaving these couples helpless, we can intervene by asking, is the embryo really the issue? Or is the maternal environment silently resisting? So let's see this case of Shawly and Benny. Shawly and Benny found us on the internet. They emailed us. They had suffered 15 miscarriages. 8 were spontaneous conceptions and 7 were IVF miscarriages, euploid transfers, and plus they had faced 4 more IVF failures. Now, we will see what happens to Shawly and Benny towards the end of the case, towards the end of my presentation. So till then, let's get back to what our subject is. In these unexplained cases, the cause could be immunological, and immunological factors could coexist with other causes of recurrent implantation failures. Why? Because we all know that our body's immune system is our body's protection against any invader. And yet, this powerful defense system is overcome in mammals in pregnancy, where the fetus grows in the mother's body, also known as viviparity. And so maternal immune tolerance is critical to the fetus, and immune dysregulation can lead to fetal rejection. Because the embryo and the gestational tissues express foreign antigens derived from the different paternal and maternal gametes. As 50% of the HLA, that is the antigens of the fetus, is from an immunologically different father, the fetus is termed as a semi-allograft, and this necessitates a critical requirement for bypassing the immune system. So, but what happens when this natural tolerance fails? When everything looks normal but failure repeats, that's where reproductive immunology begins. Whenever allorecognition is going to happen, the peripheral blood along with the decidua, with the T regulatory cells, they cause a Th2 response, and along with certain interleukins like 4, 10 and 13 are going to cause a facilitation reaction. Blocking antibodies are produced and there is protection of pregnancy. On the other hand, the trophoblast produces adequate amounts of HCG, progesterone. Progesterone-induced blocking factors, T regulatory cells come in again, and there is local immunosuppression and protection of pregnancy. And exactly reverse happens when there is failure of allorecognition. The decidua along with the peripheral blood bring in the Th17 cells, causing the Th1 response, which along with TNF, alpha, interferon, gamma, cause a rejection reaction. No blocking antibodies are produced and there is destruction of pregnancy. On the other hand, the trophoblast produces low HCG, low progesterone, low PIBF. There is no local immunosuppression and there is destruction of pregnancy. So T regulatory cells have emerged as the central players controlling everything from trophoblast invasion, tissue remodeling, angiogenesis, protecting of trophoblast from pathogens, to promoting allograft tolerance. Now, you all will agree with me that successful implantation is always a three-way dialogue where the embryo, the endometrium, and the immune system are involved. Endometrial receptivity matters, but equally important is maternal immune tolerance. And without adaptation, even the best embryos cannot implant. So embryo quality, though vital, is only one piece of the puzzle. And this is the silent conversation. And the role of a clinical reproductive immunologist is to listen to this dialogue, identify where it breaks, and restore the harmony so that the embryos transferred have the best chance to result in a cradle. So, what do we do for these patients? We investigate. Now, why it is so important? Investigations are important to rule out the alloimmune factor, and they are not just academic. They give us clinical direction. They help us select the right patients for immunotherapy, avoid unnecessary treatment in others, and most importantly, they give couples answers when everything else has failed to explain their losses. So, what are the investigations which are available? On the left-hand side are the investigations which are available worldwide, which are not available in our country by standardized labs. The investigations on the right-hand side, which are available with our standardized labs, which we say like Metropolis, Agilus, Lalpat Lab, they are lymphocyte cross-match, the peripheral blood NK cells, natural killer cells in the endometrium, serum TNF-alpha, anti-thyroid antibodies, HbA1c in the husband and the wife, lipid profile in the husband and the wife, and serum homocysteine in the husband and the wife. Now, lymphocyte cross-match is a gold standard. It measures the amount of antibody that reacts with the proteins of the allogenic lymphocytes. Negative cross-match indicates that immunotherapy will be beneficial in a particular case. Now, the endometrial NK cells, endometrial CD56 DIM cells, which are present in the endometrial lining, can mature into CD57 cells. And the CD57 cells are not supposed to be present in the endometrium. They are highly toxic to the pregnancy, can cause RPL or RIF. However, the endometrial NK cells have to be measured with the EB done in the secretory phase of the cycle or day 1 of the menstrual cycle. Endometrium is collected and sent in formalin for histochemistry, and it tells us whether the CD57 cells are present or not. Now, this is a paper which shows that when there is an abnormal ratio of CD57 cells to CD56 cells, it can result in recurrent implantation failure. Now, what is TNF-alpha? TNF-alpha is a cytokine which is produced by the immune system. As the name suggests, it is tumor necrosis factor. It treats the pregnancy like a tumor, which is a mass of growing tissue, and it is highly detrimental to pregnancy. The normal values which are there in the blood is 4 to 12 picogram per ml as per Metropolis. But when it is higher, it definitely indicates that it is going to attack the pregnancy. And in women who have failed multiple IVFs, TNF-alpha is secreted in amounts that inhibit implantation and early formation of the placenta. Yes. Now the anti-thyroid antibodies. Our endocrinologist friends always tell us that we can do nothing about anti-thyroid antibodies. Because what can we do? They will always be present. We can maximum give them levothyroxine. But anti-thyroid antibodies are extremely notorious in reproductive immunology. This study by Kute way back in 1999 showed that less than 20% of women with anti-thyroid antibodies were clinically hypothyroid. And isolated anti-thyroid antibodies without abnormal thyroid function are associated with reproductive failures. They can cause a 3 to 5-fold% increase in the miscarriage rate. And women with TAI, they develop thyroid dysfunction during an IVF cycle, subsequent pregnancy, which can lead to infertility and pregnancy comorbidities. They can affect the embryo quality in euthyroid women. Immune cells are known to regulate the thyroid levels, and thyroid autoimmunity is now known to be associated with miscarriage, RPL, preeclampsia, preterm birth, and gestational diabetes. Well, yes. Now, the role of lipids. This is one of the recent additions to our list. The M1 macrophages ingest excess lipids, which affects their polarization, thus maintaining an inflammatory milieu affecting fertility. Macrophages have to be converted from M1 to M2, that is inflammatory, to the anti-inflammatory status. M2 macrophages are the main antigen presenting cells to the T memory cells in the uterus, which promote healthy implantation. M2 macrophages in the male genital system also help from sperm production, maturation, zinc production, and sperm function. So M2 macrophages in the endometrium lead to an anti-inflammatory environment favoring implantation. So we see that all these tools help us to identify which patients are going to require immunotherapy, or we say immunomodulation. Now let's talk about what do we treat? What do we do traditionally? Traditional approaches are steroids, IVIG, intralipids. However, they suppress, but they don't re-educate. So they are not effective when they are used alone. The goal in any treatment of reproductive immunology is to restore the maternal immune tolerance to the fetus with active immunomodulation and enhance tolerance mechanisms by the subsequent passive individualized treatment. Active immunomodulation is always effective. It is long-standing. It mimics the natural protection of pregnancy and it is safer. These are all the available immunomodulatory treatments. Well, Immulate. Immulate is our patented and branded process of Dr. Raut's Center of Reproductive Immunology, which is based on lymphocyte immunization therapy. This is an immunotherapy where we use another person's lymphocytes other than the patient's, called allogenic lymphocytes, to prime the mother's immune system. Well, LIT is not new. Way back in 1953, Billingham et al. Had observed that there is something in the blood which, when exchanged, helps to tolerate the grafts better. However, it was Professor Alan Beer in 1985 who identified, researched, and perfected the technique of lymphocyte immunization therapy way back. So what is the mechanism of action? This goal of this is to stimulate the production of the blocking antibodies, which I had described in the slide before, and to promote the regulatory cells that promote embryo acceptance. It is a simple, the way we do it is a simple one-day procedure with excellent safety. And this is followed by individualized passive reproductive immunomodulatory medicines. Now, there are many studies way back from 1997 till today, which prove the efficacy of LIT. The recent meta-analysis also by Cavalcante et al. Have shown that there is a chance of a successful live birth is 3 times more when LIT is given to women with reproductive failures than not giving. Global studies have also shown the same thing. On the right-hand side, I've put up our studies, which have also shown that they are safe and effective, and they are cost-effective and safer than IVIG or any other biologics. So let us see what happens to Shawly and Benny. Shawly and Benny came to India. They stayed for 8 days. They did the tests and they took Immulate with us, went back to the UK, to Ireland, and there they took all the passive immunomodulatory medicines which were prescribed by us. Shawly conceived naturally, yes, but the loom of miscarriage was still there. They took all the individualized passive immunomodulatory protocols and now they have a baby boy. So, the role of any immunological investigation or any treatment is to identify and to defeat the immunological enemy. And in doing this, the clinical reproductive immunologist will never replace an IVF specialist. We act as catalysts alongside them. We provide one more tool when conventional explanations fall short. So my take-home message is not all failures are embryo-related. Maternal immune tolerance is equally critically important. Immunological investigations reveal hidden causes, and LIT restores acceptance, improves implantation success. So when good embryos fail, think immune. When science meets hope, failures turn into families. I would like to end my talk with the words of Sir Peter Medawar, who is considered to be the father of reproductive immunology, and he was also a Nobel laureate. The purpose of science is to change belief. And if you believe that infertility, implantation failures, recurrent miscarriages are God's will, which is not treatable scientifically, you will never try to find an effective treatment. Thank you very much.
Thank you, Dr. Mukta. Over to chairperson.
Wonderful.
Thank you. Thank you, Dr. Linda. I'm Dr. Bedi here from Chandigarh. It's
Yes,
a
ma'am.
wonderful
Recording in
presentation.
progress.
And we all know as IVF specialists, we are dealing with a lot of RA patients. And I think the best line which I liked was that when good embryos fail, think immune, which we as IVF centers are still not thinking immune. So I think it's very important take-home messages. Yes, when we've given a good embryo, especially euploid embryos, and when they fail, you really don't know what to tell the patient or counsel the patient next, because you feel that you've done your best, and according to the patient, you have done your best.
Thank you so much, madam. Thank you for your kind words.
It was wonderful presentation, Dr. Mugdha, and you have made it very easy, actually, very easy. So I have one question because there are two schools of thought here. That some would say that you do NK cells, some would say you do Th2 Th1 ratio, some would say you do HLA typing and those details. So what do you exactly suggest? How should we go ahead, either RIF or RPL patient?
Madam, yeah, one question is that this Th1, Th2 ratio is not available in India with standardized labs. So we don't recommend it. Abroad it is done, but it is extremely expensive for our patients. And regarding, madam, about immunogenetics or HLA typing, if you can say, we always say that it is genetics. It is not an actionable step. When we know that there's this problem, it's like someone is having the BRCA gene. It doesn't mean that every woman having it is going to develop breast cancer. So every woman has to undergo a mastectomy. But we know that the risk is higher. So they have to be aware. But what would be an actionable step? Actionable step is to help the body to produce antibodies, which the body is not producing. That is why lymphocyte, the LAD test, which it is called abroad, or we call the cross-match test here, is supposed to be the gold standard. So immunogenetics is a predictive test. I'm not saying it is not right, but what can we give an action? Because like I said about the BRCA gene, not every woman is going to develop breast cancer. So every woman with a genetically, with a HLA this HLA typing, which shows there's a higher risk of miscarriage, is going to develop. But yeah, we need to be careful for that. But it's not necessarily it is going to be the same thing. So, and madam, it's not only about, because the HLA A, B, C, D types are there. Now, HLA G is actually one of the most important HLA on the embryo. And no one actually looks at HLA-G. People talk of HLA, and there's so much of dynamics happening. Okay, which embryo is going to be accepted and which is not going to be accepted is going to be decided at the uterine level by the immune environment. So even though I will say that, okay, this type of HLA in the mother, HLA, this is there, it's called KIR, madam, is there, and this type of HLA is there in the baby. What is going to happen ultimately at the microenvironment is still not known. There is lot of polymorphism and lot of dynamics happening. So HLA-G is now being considered as the most important. It is very difficult to quantify it, because it is very, we say, volatile. It doesn't last for a very long time. But now they are doing a test where they can do the HLA-G in the spent media. And that will probably help us know the success of IVF. of that particular cycle. So if HLA-G is in higher amount, probably that cycle is going to be more successful.
We have few questions in the chat box. One question by Dr. Shreya Matur. With so much evidence in favor, why is LIT not yet endorsed and even discouraged by global guidelines?
Okay. So this is a very, very important question close to heart. LIT was very, very widely practiced till 1999. And it was globally practiced. It started in the US. It is still being done in the UK. It is done in Germany, Australia. It is done in the Middle East, some Middle Eastern countries. In Japan, it is being done. But there was a review which came up in 1990 by it was called the Ober study. Now, I could not put all that up because of time constraints in this presentation, but there is a separate presentation where we talk about this whole thing, why it is, if it is so good, why. So there was a study by Ober which actually did not follow all the particular points which had to be followed to use allogenic lymphocytes, and that's why the study actually showed that LIT is not beneficial. Now, unfortunately, the Cochrane review, which came subsequently, was heavily based on the Ober study. So that's why everyone kept saying that LIT is not beneficial, and US FDA kept it on hold. They wanted more trials, which they're now opening up again. They want more trials. They are getting studies from different countries. But LIT was being done by the time was being done in Mexico, in Brazil, in Argentina, in the UK. So LIT continued over there. And still it is being continued in UK. In UK it is done. I'm not saying all the doctors do it, but there are very few select doctors who are doing LIT in the UK. And in Germany also, there is the largest study of safety came from Germany by Kling in 2005. And he has studied 4,500 women. So the safety study came from Germany. So because US FDA has kept it on hold, it is still believed that other countries' FDA is not allowing it. So I think everyone should now start doing in India.
Okay. One more question is there. Is higher lipids associated with if higher lipids associated with the RIF, should we prescribe statins?
Yes.
Or not?
Definitely, we should prescribe statins. If time would have permitted, I would have spoken a lot about statins and the lipid profile. But there are two types of statins, hydrophobic and hydrophilic. And hydrophilic, the two important ones, which are rosuvastatin and pravastatin. Now, pravastatin is not available in India, but abroad they started well before and they continue it throughout pregnancy also. It's a hydrophilic statin. So what we do is that we use rosuvastatin. We use rosuvastatin for 2 months after LIT and before the embryo transfer has to be done. We recommend. We don't do IVF at all. We don't even do our regular gynec practice. We only do clinical reproductive immunology. So we recommend after Imulate, a course of 2 months of rosuvastatin. And then we see that the lipids have come to a reasonably low level, almost near normal. And then the embryo transfer should be planned. So rosuvastatin is a drug of choice for this M1, M2 macrophages.
Chairpersons?
I have one question. Madam has mentioned that for men, you recommended checking homocysteine level and lipid profile.
Yes.
So usually when we talk about pregnancies and recurrent pregnancy loss, we always focus on women. So can you tell us why you are focusing on men?
So there is a lot of this about sperm function. What we look at is sperm morphology. But right from the Sertoli and the Leydig cells, the lipids are required. Lipids are required for the hormone production, for everything. But excess lipids are again ingested by the M1 macrophages. M2 macrophages are also present around the Sertoli cells and the Leydig cells. And that's why the sperm production gets affected. Subsequently, as they travel along, M2 macrophages build an immune tolerance environment in the entire male reproductive tract. And therefore, what we feel is that just a nourishment along the male reproductive tract is not nourishment. The maturation and the function is highly affected by the tolerogenic immune environment in the male reproductive tract. So there also they need an anti-inflammatory milieu. And that's why if embryos are frozen, we can't do it. But if embryos are not yet frozen or not yet formed, we highly recommend bringing down even the male lipid levels. So even the acrosome reaction is known to be better. And homocysteine is an inflammatory, it causes inflammation in all the blood vessels. Inflammatory milieu is going to again take it to a Th1 milieu. So even in as important it's an implantation for women, it is also important in sperm function, sperm maturation. And the funniest part is M2 macrophages are required for even zinc production in the male genital tract. So it is so important that even the male should be equally healthy, and the lipid should be down to be helping the sperm function better. And the acrosome reaction is definitely known to be different.
Thank you.
Any other questions?
I think there is a question in the chat box which says, do you recommend the number of embryo transfer also after these treatment, either single embryo transfer or the 2 embryos?
No, we never recommend. It's completely up to the IVF specialist, because what we work on is not how much of, as I said again, it's the protective antibodies which have to be formed. We work on the adaptive immune system. So whether it's a single embryo or double embryo, or even if 3 embryos are transferred, nothing is going to happen as long as our procedure is done. So we never recommended the number of embryos to be transferred.
Okay.
And it is not believed worldwide, it is not believed that the number of embryos will affect, because it depends on the antigen which is present on the embryo, which is going to stimulate the dendritic cells, and they are going to go to the lymph nodes where T memory cells are also present, and they are going to produce T regulatory cells and the B cells. So if we've done our work properly before, the number of embryos doesn't matter really. Because I know it, I've heard about it, it's based on a lot of immunogenetic concept of C1, C2. But I said
they recommend you transfer a single embryo, because the embryo gives the load of less number of the genetic material or allergic, whatever. So they recommend like that.
Yeah, but madam, we have never recommended. We are doing this from, I think, 1991. We've never recommended the number of embryos, because it completely depends on the principle of adaptive immunity. So it really doesn't recommend. We don't recommend.
Okay, ma'am.
Okay. If there are no other questions, thank you, Dr. Mukta. I think for this such a topic which is quite evolving day by day, and still we have got long way to go.
That's true, sir. Lot of research needs to be done still, sir.
Thank you once again. With this, we will go for our second topic. It is on adnexal masses and ART, when to watch and when to act. And first we have the chairpersons, Dr. Parshuram Gominath. As you all know, Parshu is the medical director of CIMAR Women's Group of Hospital, unit of Edappal Hospital in Kerala, scientific director of the CIMAR, and the teaching faculty at Edappal Hospital, National Board Accredited Center, and FNB Accredited Center in Reproductive Medicine and High-Risk Pregnancy and Perinatology.
It's okay, sir.
Consultant at several hospitals. Also received a Manish Bangar Young Achievers Award for Clinician, ISAR 2020, Champion of ISAR Award, MQR ISAR Young Talent Award, ISAR Mayor Youth
Yes, sir.
Icon Award.
Okay.
Okay.
Thank you, sir.
Okay. With then let me invite our second chairperson. It's none other than our Tarini Tanija Madam. She's a consultant laparoscopy and IVF specialist at IVF Center in Delhi and Muzaffarnagar. Presently, she is the president of ISPAT Delhi State, Honorary Secretary South Delhi IMA, President Mansli Rehat and NGO, and she has received a number of awards and number of publications are in her credit. Because of lack of time, I am not reading all of them. A few of them are Foxy Breast Committee Award, Bharat Gavra Samman Award.
It's okay, Dr. Fesi. Thank you so much for kind words.
Okay. Our next chairperson is Dr. Prerna Shinde.
It's okay, Dr. Fesi. We can just skip this. We'll just, yes.
Okay. One word, she's the Shinde Hospital Director and Test Tube Center in Shirampur, an obstetrician and with a vast experience of more than 33 years, practicing infertility for 23 years. And over to chairperson to introduce our speaker, Dr. Kunjumoideen. Dr. Parshu.
Yeah. Let me take this opportunity to introduce the next speaker, Dr. Kunjumoideen, with a vast experience. I think we can. So, is a senior consultant at ARMC IVF Fertility Center and the founder and managing director at ARMC IVF Centers India. He's also the founder chairman of ARMC Aegis Hospital, Pendalmanna, a visiting consultant to many hospitals in India and abroad. He's the founder secretary of the IFS Kerala chapter, founder president of the Pendalmanna Society. He was the immediate past president of Kerala Federation of Obstetrics and Gynecology and also the Kerala chapter of ISAR. Invited to many conferences and authored chapters in different textbooks. And he'll be talking on a very interesting topic of pelvic adnexal masses in this field of reproductive medicine. And probably this is a field where we always try to ignore and just make sure that we just go do our job of doing our own pickup and going ahead with trying to get them pregnant. But a lot of times, and some kind of adnexal mass which probably needs to be evaluated and treated probably are missed out. So over to you, Dr. Kunjumoideen, and looking forward to listening from you.
Those are attending in the delegate link. If you have any questions, please put in the chat box.
Yeah, thank you, Dr. Parshu, for the kind introduction. And some 5 years back, CV has been shown. Sorry for that. And currently, I'm attached with Birla Fertility and IVF Calicut and Perinthalmanna. And thank you, Dr. Fesi, the organizers, Dr. Amit Patki, Dr. Asha Bakshi for having this wonderful platform to discuss a lot of interesting topics. And the topic adnexal masses and ART, when to watch and when to act. Actually, the topic caption has been coined because very often during stimulation, when we start stimulation or during embryo transfer or when we prepare the endometrium, very often we neglect this particular entity and we just go ahead because of a lot of things. We just go ahead with the stimulation or endometrial preparation. But in what all situations we can neglect, or what all situations we need to watch, and what all situations we need to act. So that is the actual part of today's discussion. And why this topic matters in ART. Because adnexal pathology is common on baseline transvaginal ultrasonography in IVF patients. Very often we see. And decisions change stimulation, retrieval access, and complication risk. Not only the direct complications in the form of failure of that particular cycle in spite of transferring very good embryos. And overtreatment can decrease the ovarian reserve, undertreatment can decrease the IVF success rate. And there is something which we have to balance, that is the oncological potential of many of the masses which we may neglect. So the framework of decisions that will be revolving around 4 is assess, that is ultrasound pattern by IOTA or ORADS, size, symptoms, and tumor markers. These are the things which we have to assess and categorize. Second, aim, pain relief, access of the ovaries during ovum pickup, IVF outcomes, and it should be safe with regard to the oncology point of view. Third, A stands for act. Observe, it can be just observation, medical suppression, aspirate or sclerotherapy in some very rare cases, surgery in some situations, and refer to the oncologist in some very rare occasions. Fourth one is after, that is timing to stimulation or effect on the ovarian reserve as well as the live birth rate following your IVF cycle. So the first is imaging and risk stratification. TVS ultrasound is the first line of investigations and apply the International Ovarian Tumor Assessment simple rules and adnexal model. Or we can categorize as per the basis of ORADS. And in some situations, MRI for indeterminate or complex lesions before ART is a must, but always we have to keep in mind there is a small percentage of malignancy in many of the situations. And use structured reports in the fertility chart and note it down and properly follow it up. So International Ovarian Tumor Analysis is one of the research consortium that provides simple rules and adnex model for adnexal mass classification. And it has high diagnostic accuracy for differentiating benign versus malignant ovarian lesions and widely validated across multiple populations across the world. Ovarian adnexal reporting and data system, that is ORADS, very often we see in the ultrasound report by the radiologist, this ORADS 1, 2, 3, 4, and 5. Developed by American Society for Radiology and American College of Radiology, updated in 2022, and standardized lexicon and 5 risk categories are there, and link ultrasound features with the recommended management. So that is the actual prognosticating factor in this, and promotes consistent communication between the diagnostic radiologists as well as the ART clinicians. And it is a safe triage before stimulation so that we will not land up in unnecessary troubles, specifically surgery. So what is ORAD 0? That is incomplete study, not technically adequate or incomplete evaluation. So we need an additional modality or a repeat imaging. ORADS 1, that is a normal ovary. 2, almost certainly benign. And 3, it is low risk, that is indeterminate lesions without suspicious features, multilocular cyst, smooth solid of less than centimeter, and follow-up or surgical evaluation depending on the situation. ORADS 4, it is intermediate risk which requires surgical evaluation. 5, it is high risk for malignancy. And standardized lexicon is a structured dictionary of terms which describes cyst type, wall, septations, solid component, vascularity, and echogenicity to ensure consistent description and reduce variability between the radiologist and the clinicians. And coming to the tumor markers, CA125 is unreliable and endometriosis used only if ultrasound is suspicious. But here we have to keep a situation where the ultrasound is showing a small endometrioma. If the patient is being planned for ART, we never think about surgery. But on the time of embryo transfer or during stimulation, if the cyst is showing very high CA125, you have to think twice before starting the stimulation and do further investigations regarding the malignant potential. Then HE4 and trauma may aid referral decisions, not screening tools. Any ORADS 4 to 5 or suspicious clinical picture, gynec oncology consultation is a must. Then the tumor marker tunes in adnexal mass, human epididymis protein 4. It is a serum biomarker overexpressed in many epithelial ovarian cancers, more specific than CA125 and less affected by menstrual cycle or endometriosis. Risk of ovarian malignancy algorithm, that is a logistical regression algorithm combining HA4, CA125, and menopausal status, basically the age. That will stratify the risk of that particular adnexal mass. And in ART practice, it is not for routine screening, but helpful when ultrasound shows indeterminate suspicious mass and we need a referral decision, and should always be interpreted with imaging. Sorry for that. So we have to keep in mind the recurrent endometriomas, the risk of malignancy is not very small. It is around 6 to 8% malignancy risk is there. So that we have to keep that in the background of our mind. So the functional cyst at baseline, that you can see a follicular cyst here or a corpus luteal cyst here in the ultrasound, it often regresses over time. An observation or short OCP or GnRH and antagonist pre-treatment will be enough. If the patient is in urgency to start stimulation, very often that cyst will regress with 2-3 doses of antagonists. Agonist cyst downregulation if E2 is elevated before start of the stimulation, and proceed with stimulation if hormones and access is acceptable. If it is an inert cyst, we can very well go ahead with the stimulation. You need not stop your cycle, and that is very important. And this is a rarest of the rare thing that sometimes we may need to aspirate if it is impairing, if it's a large cyst but doesn't require surgery, but you can just aspirate it. Endometrium and ART, it is a long-term consensus that if we are planning for ART or if it is indicated for ART, we should not touch the ovarian cyst because the presence may decrease mature oocytes, but the surgery will further reduce the ovarian reserve. Injury to the ovarian reserve, infections at retrieval, all these are the risk for the endometriomas in ART. And cystectomy, basically stripping, that is, there is consistent AMH decline. And if it is bilateral or recurrent endometrioma surgeries, the situation will again worsen. So that's why, unless otherwise there is severe pain or we suspect malignancy or the oocyte retrieval is not accessible, then only the surgical modality is indicated. But when to watch an endometrioma if you are not doing surgery, classic ultrasound features of less than 4 to 5 centimeter, asymptomatic, just to observe. AMH or AFC is adequate, retrieval is feasible, don't touch. No rapid growth, tumor markers are not concerning, nothing to worry. So proceed to ART and avoid routine excision. So when to act, suspicious or atypical imaging or rapid growth, excision or oncology opinion, severe pain or deep disease requiring deep infiltrating endometriosis surgery, transvaginal access is clearly impeded so that you are not able to see the developing follicles, and recurrent infections or prior difficult retrieval. So in that such cases, you need not do extensive surgery. Rather, you can do a laparoscopy and aspirate the cyst and clean it. If acting, how to act? Laparoscopic cystectomy standard when surgery is indicated only. So nowadays, the laser ablation also is coming into practice where you need not peel the cyst, whereas the advanced lasers are available to just ablate the cyst. And aspiration and sclerotherapy is very much researched because generally we don't do nowadays because of the very high incidence of ovarian abscess incidence. And do not operate solely to improve ART outcomes. Surgery for pain and multidisciplinary care is important. Timing of ART after surgery, wait 2-3 months for ovarian recovery. Even if AMH comes down, that will be mostly temporary. If the surgery is good, recheck AMH or AFC, anticipate the poor response, consider oocyte or embryo cryopreservation before the bilateral or redo surgery. And this is very applicable in the recurrent endometriomas. And hydrosalpinx. Now we thought about the follicular cyst, we thought about endometrioma. Now another situation is hydrosalpinx. Very often, post endometriosis surgery, you might have thought that everything is clear. By the time you are taking up the patient for either for the stimulation or on the day before embryo transfer, you may see hydrosalpinx there. What should we do now? So basically, hydrosalpinx is that will negatively affect the pregnancy rate to a great extent. Toxic reflex into the cavity that will affect the implantation. and can cause miscarriage. And treating hydrosalpinx by clipping or excision that will considerably improve the pregnancy or live birth rate. And laparoscopic salpingectomy, that is the best evidence preserving the ovarian response. And proximal tubal occlusion. Nowadays, very often by the time you see hydrosalpinx, it will not be the isolated hydrosalpinx. Very often you can see the frozen pelvis and so on. So you may not be able to access the full length of the fallopian tube in such situation, just dealing the fallopian tube. And that will be because our aim is not to have this fluid going into the uterus. And sometimes the clipping also can be done. And paraovarian or simple cyst, usually benign, most less than 5 centimeter can be observed, act if large, symptomatic or indeterminate. And aspirate intra-op only if surgery for another indication, and document stability across various cycles. And this is another situation in sometimes it's not very rare we come across small dermoid cyst which may be noticed on the day 2 scan or when you are doing the FET preparations. Basically, it is having low risk malignancy risk, but torsion risk increases with the size as the size of the cyst increases. Watch if classic ultrasound is less than 5 centimeter or asymptomatic. Remove if it is more than 5 to 7 centimeter or showing growth or symptoms or access concerns. Laparoscopic cystectomy, avoiding the spillage in an endobag, that will be the best thing. And adnexal torsion in stimulation and pregnancy. You know, because of the hyperstimulation, the ovaries will be enlarged, heavy, and that is a situation where it can undergo torsion. So whenever the post-ovum pickup, the patient is complaining severe pain, this also have to be kept, we have to keep in mind. And the risk increases with enlarged ovaries, dermoids, and long pedicle ovaries. Incidence after ART is low but significant. Prompt laparoscopy and detorsion to preserve the ovary and proceed with ART cautiously after recovery. And masses suspicious of malignancy, borderline ovarian tumor, apply the proper grading by IOTA or ORATS. And if more than 4, risk gynec oncology referral is essential. Fertility sparing options exist in early borderline tumors or early malignancies. Do not stimulate until oncologic plan is in place, and proper scoring is essential. Fertility sparing after cancer or borderline ovarian tumors. What all things we have to? Follicular stimulation is safe in selected ovarian cancer or borderline tumors. ART, yes, it is possible post fertility sparing surgery surveillance. And consider letrozole along with the stimulation plans where the ER is positive, estrogen receptor assay is positive, counsel on recurrence and pregnancy timing. And in these situations too, there may be this timing is either between the diagnosis and chemotherapy or radiotherapy, or between the surgery and the post-surgery chemotherapy. You may have very little time. So ideal is to have the random start stimulation protocols. Scoring, AMH, AFC, Antrelmap for retrieval planning, MRI in certain situations, and document the scoring. Retrieval access planning, what all things? Map, cyst, and safe needle paths. Why? Because we have to avoid going through the cyst as much as possible. If access is impossible, pre-treat only to enable retrieval. Antibiotics when puncturing near an endometrioma. You may go through the endometrioma, come back, you have to notify the embryologist that this is fluid, maybe there in the aspirate. And very rarely we may have to cancel the cycle. So medical suppression, when it is helpful, in the benign cyst, OCPs or short GnRH antagonists to quiet the functional cyst to make it non-functional so that it will not generate more estradiol. And GnRH agonist pre-treatment may shrink endometriotic lesions, but very rare to happen. Consider for symptom control, not cyst treatment. Avoid long delays that worsen age-related decline. Aspiration and sclerotherapy, just for the theoretical sake. Don't go and try aspiration unnecessarily because that can create a lot of ovarian infections. Hydrosalpinx on stimulation day, what now? If newly visible, pause and treat before transfer. So you can go ahead with the stimulation retrieve the oocytes, freeze the embryos, then reassess again, then remove the hydrosalpinx or clip the hydrosalpinx. So avoid fresh transfer with active hydrosalpinx. Pregnancy with residual cyst monitoring is essential. Most simple cyst or endometrioma is safe in pregnancy. Counsel on torsion symptoms, low threshold for review. Avoid elective surgery in the first trimester unless suspicion is high. And an obstetrics team coordination is very essential. So counseling and consent, these are the key points. Discuss reserve impact, ovarian reserve impact versus the ART benefit. Clarify all the indications for an intervention, pain, access, oncological or hydrosalpinx presence. Observe alternatives, observation versus sclerotherapy versus surgery. So we have to explain those details. Document all shared decision making. So discuss, clarify, observe, and document all the points regarding this. So the practical algorithms: watch versus act. Endometrioma less than 4 to 5 centimeter, benign by ultrasound, accessible. You will not worry about it most of the situations. Hydrosalpinx confirmed, treat before ART, basically before embryo transfer. Dermoid of more than 5 to 7 centimeter or access risk, consider cystectomy. Indeterminate or ORADs 4 to 5, an oncology evaluation and documentation is a must. So the take-home messages: when to watch, when to act. Watch: benign features, small, no access issue, normal reserve. Act: situations like hydrosalpinx or indeterminate mass. Use the documentation protocols like IOTA or ORADs and individualized with patient's age and goals. So thank you for the patient hearing. Before winding up, we are organizing our 9th annual All Kerala ISAR chapter conference at Calicut on 1st and 2nd November. The details are available at akisar2025.com, and the registrations are open, and we have a fantastic opportunity on all aspects of ART for abstract submission. Thank you.
Thank you, Kunjumoideen. Over to chairpersons for the questions. Chairpersons.
Yeah. Sir.
Hi, Dr. Kunji. Hi, Dr. Kunji. It was really eye-opening. When to, act. It was really good. But I just want to know when the bilateral endometrioma, so one question. And the patient is having pain also. And it's around 4 centimeter. In that case, what to do? Only watch or act?
No. See, in endometrioma for ART, if ART is indicated, maybe because of the male factor or due to the long-term infertility and the patient ovarian reserve is coming down, and if it is ART is indicated, we have to weigh the balance whether the pain to be treated or we have to initiate the ART. So in such situation, if the patient is in severe pain, that our first priority has to be alleviate the pain. So earlier we thought the pain, the first attempt should be to do surgery. I think we need not do surgery or try surgery at the first attempt. Now with the advent of PPOS protocols, we can very well put the patient on Dyno first and Dynogest, and we can continue Dynogest for some time. The pain will be relieved. Even when the patient on Dynogest, you can continue the stimulation. That will be considered as progesterone for endovarian stimulation. We need not even add antagonists, so we can retrieve the oocytes. That is one option. Second option is, if you are comfortable with starting the medical treatment and relieving the pain, we can very well go ahead with the surgery. But surgery should not be stripping of the ovarian cyst because the patient is planned for ART. Just the cyst aspiration, removing the adhesiolysis, those things will relieve her pain. Pain usually will be due to the pulse of Douglas endometriosis.
Okay, thank you so much. Thank you.
Dr. Konji, it was really nice, and overall, I think everything has been covered in your short period of time. And these are the troubleshoot, like the moment we decide to take patient for the stimulation and when do first baseline transvaginal scan, and the topics which you have covered, it is really insightful, especially regarding endometrioma, regarding hydrosalpinx and all. So I don't think so. We need to add add in anything, and you have answered most of our questions. It was a really nice presentation.
Thank you.
Sir, one question, sir. See, especially when you're especially with these dermoids, which are not very big, like 2-3 centimeter dermoids, where we don't know whether we should remove it before and do at the home pickup. Is the possibility of it we having to go through the cyst dermoid, or if there is spillage at the time of an home pickup? What has been your take on it? Do you think we should be removed before the surgery, or even if it's a little smaller size? I'm not talking about very small size, but again, say 3 centimeter, 4 centimeters, one, like probably because we might have to go through it, no, for an home pickup. What is your take on it?
Yeah, actually, as per the guidelines, we need not remove the surgery and we need not remove the dermoid before stimulation, anything which is less than 5 to 7 centimeter in the last slide I mentioned. So generally, this dermoid cyst, if it is small, 2-3 centimeter, we can easily avoid. But 4 to 5 centimeter, like you said, there is a high possibility that we may go through. Unlike endometrioma, the dermoid cyst spill theoretically can cause chemical peritonitis and so on. But to be frank, I've been doing laparoscopy for last 2.5 decades, spilled dermoid cyst a number of times. We see, not even once we have seen the chemical peritonitis. I think chemical peritonitis exists in only in the textbook. So I don't think nothing to worry about it.
The question why I asked was because actually the same thing, even several dermoid cysts and all, we have done surgery, we have done so many cases, but we just had a recent case where there was a spill which we had washed also quite well, but the patient developed, I don't know what it is, I don't think it is a chemical peritonitis or some, it kind of a granuloma that developed in multiple parts of the abdomen. So which I don't see any other reason other than the spillage, because otherwise the
What
issues
is the biopsy report, histopathology report was only dermoid?
Yes, it was only dermoid.
Yeah, there is some situation which is described as borderline dermoid with borderline potential. In that situation, these granulomas are being reported. Borderline potential. So basically, that granulomas have to be biopsied.
Yeah, actually, the granuloma was biopsied, and they said it's only granuloma. So the whole thing is that what exactly? So because even
And
like
they are negative for tuberculosis, right?
yes,
Because in Kerala, we generally don't check for tuberculosis, but
did check for tuberculosis also. So anyway, I think we had referred the patient to a gynec onco, and then they said they will they will take care of it. But like you said, I asked several people regarding what is the actual signs and symptoms of a chemical peritonitis. Nobody was talking about it because nobody knows, because they've not seen it. Everybody has spilled it. Everybody have seen that they've not much of a problem. But then very, very rarely that a situation like this come, and that we are in
so
corner.
in the workshops or in the recorded videos, we generally show, we just
Parshu,
cover the part of spilling. Remaining things we'll show.
Yeah.
Parshu, Gobi sir always tells one case which occurred in 2000 in Edapal, where one patient had developed post-surgery a laparoscopy for dermoid cyst. Patient developed acute abdomen like, and when it was opened, it was pseudomyxoma like. That was a post. This occurred many years back, maybe 25 years back. So even though and I at that time afterwards, when I discussed once with Shamdasai sir also told one case he had seen a few years back. So it is rare, but it can occur, especially if it is head low position. If you don't wash in between bowel, maybe some irritants, but when doing pickup, the chances less, I think, because it's only needle this thing. Even then can occur, but it is very less.
And the endometrioma, the reason for passing through it, because ovary will be very fixed.
Adherent and all those things.
Whereas dermoid, you can even just manipulate also.
Thank you, sir. Thank you.
Thank you.
I think, rest, if any questions we can, as we are running late, we'll go for the next. Thank you, Kunjumoideen, for enlightening us. I think for this is how systematically we will look into the adnexal mass, especially being ART specialist. Once you commit for ART, people will be reluctant to go for a surgery. Both the doctors and the patients will be reluctant. So you correctly pointed out all the points. If no other questions, we will go to the next panel. We have Dr. Shivani Gaurav as the panel moderator. First, I will introduce Dr. Shivani, and she can introduce the panel members. And it is the different case scenarios in infertility. Dr. Shivani is a director of SCI IVF Hospital, ex-clinical research fellow, Imperial College and Hammersmith Hospital, NHS Trust, UK, featured in Limca Book of Records, and founder secretary of Delhi chapter of ISAR, general secretary of INSTAR, general secretary of Delhi chapter of ISPAT, ex-vice president Delhi Gynec Forum South, vice chairperson of Women's Doctors Wing of IMA South Delhi, and more than 10.
Thank you so much, Fessy. Thank you. Actually, we are running late.
Okay.
And I will have to leave by 9. So if we can start with the discussion. Thank you.
Please introduce the panel members and start.
So it is a great honor for me to be here. Thank you, my dearest Anu and Dr. Fessy, and with deep respect to our President, Dr. Amit, Dr. Asha Bakshi, Dr. Reshma, Dr. Neena, all our guests. I would like to start this panel discussion by introducing our panelists. And of course, dearest Tarini ma'am, it is so nice to see you. Dr. Neelam Bhise, she is the fertility specialist and IVF consultant since 2012, managing committee member of ISAR and MSR, and postgraduate IVF course trainer from Acme Fertility Academy. Somebody's laser pointer is using, is that moving? Is that mine? I cannot see anything. And ART clinician.
Thank you so much, Dr. Shivani. Thank you so much. You can proceed on the next.
Somebody's laser pointer is moving. Pata nahi. Next slide. Kaun dal raha hai for the next panel?
Yes, ma'am. It is I'm actually sharing the screen. So for easy readability, if you want, I can switch it off.
Dr. Gunjan Gupta Govil, my dear friend, welcome Dr. Gunjan. She is a winner of North India's best IVF chain and trusted chain, and Hall of Fame in the Endoscopy and Foxy Achiever Awards, and she has now also got her affiliation with I think Amity University. So welcome Dr. Gunjan. Next. Dr. Namrata Ray Ori, she's a diploma of medical legal system and ART, and has done her course in obstetrics and gynec ultrasound from Chennai. And currently, she is a consultant in New Life in Varanasi. So welcome, Dr. Namrata.
Thank you, ma'am.
Tanuja, Dr. Tanuja Bora, she's working as the program director of IVF at Nova in Haldwani, Uttarakhand, and she was the former consultant at Santan Fertility Center and Amri Hospital in Bhubaneswar. She's worked as a fellow in reproductive medicine at Kraft Hospital in Kerala, and laparoscopy also, and diploma in ART. So welcome, Dr. Tanuja. Very nice to have you here.
Thank you so much, ma'am.
And dearest Niharika, how are you? You welcome us all so many times to Lucknow. So it is really honor for me to get a chance to welcome you now. Consultant in infertility and fetal medicine with a fellowship from Chennai, and in critical care obstetrics from Safdarjung, prenatal genetics, AMG, fetal surgery, FMF, and IVF training in Japan and Barcelona. So she is fully rounded, competent in so many specialities. Really dazzling CV, Dr. Niharika. Welcome.
Thank you. Thank you, madam.
So now, let me share the. So I have to share my screen, right?
Yes, you can share. You can share.
Okay. And वो उसके पीछे है. So we will try and get as much covered as possible. Let me just minimize this. Right. So my first question now, this is not, to anyone who feels they would like to answer, you are most welcome. So 29-year-old female working in IT, married 1 year, irregular periods, acne off and on, known case of PCOS, was on pills. She got married. Now sister conceived with IVF and at GDM. So our patient is worried that she may also need the same, but right now she has come to you. She wants natural ways to conceive without any hormonal medication. So, what would be your first suggestion? Anybody?
Ma'am,
Yes.
I would like to take this.
Yes.
So, in this, she's a 25-year-old female, and she's a known case of PCOS with a BMI 27. And she had a sister who has conceived with IVF. Ma'am, her AMH is
5.
6.5. So, I will counsel her that if her AMH is fine, and if I'm seeing the good amount of antral follicle count also, she can conceive naturally. I will reassure her, but definitely at the same time, seeing her BMI and other factors also, I would like to investigate in this.
Okay, is anybody else in favor of investigations, or would you like to give her some counseling first?
Ma'am, I would like. Yeah.
Counseling first, ma'am.
Counseling.
Right. So basically, when she comes to you, you are going to first of all look at her weight, her blood pressure, ask her about smoking, alcohol, diet, exercise, emotional, sexual health. And first thing you are going to do, because she has already got her ultrasound and her hormonal profile done, you will advise her about diet and physical activity. So please give me an idea about what diet will you advise this patient?
So basically, for this patient with high BMI, I would like to advise her not only a proper diet, but a lifestyle modification with physical activity as well. In case of diet, I would like to tell her to reduce the calorie intake. So the total calorie intake she can reduce and go to around 2000 kilocalories per day. Along with that, she should limit the carbohydrate intake and increase the protein intake so that she can manage the food cravings as well. So now these days, lot many diets are available. Like people are doing intermittent fasting, they are doing keto diet, somebody's doing Mediterranean diet. Whatever suits the patient. So the overall goal should be a calorie restriction.
Excellent, very good. And what about, yes, what about physical activity?
That is very important. So along with the dietary part of the counseling, the lifestyle modification is also very important. So a moderate amount of activity, which can be 45 minutes of exercise per day for 5 days a week, and moderate intensity of exercise, it's good for the patient, and that is very achievable. She need not do it every day, and she should, and with strength training, that I advise my patients. It is easier.
Excellent. So the standard recommendation is 250 minutes at least in a week of moderate intensity, and at least 2 days you must do some muscle strengthening exercise also, and 2 non-consecutive days in a week preferably. And this is for the loss, and for maintenance, it's 150 minutes per week. So that means at least 22-23 minutes per day, and 75 minutes if you're doing vigorous. And what about the role of metformin or myo-inositol? How many of you would prescribe metformin or myo-inositol?
So I would want to add here.
Yes, sure.
So I concur with our my co-panelists that apart from like all these advices have been given, 2 points I would want to enlighten here for the medication part. One is the patient has seen the journey of a person who has done an IVF and they are scared of doing an IVF. Another point is they don't want to face GDM during pregnancy. and she's come at the right time. Only thing that we might have to tell her that at least she should give her 1 year, because that is where she will be counseled, like 1 year for natural conception, if not at least 6 months. During that time, when we are doing diet, exercise, and everything, patient would want, because it's a first sister, so patients would want a little bit more medical support in terms of weight loss and glycemic control. And of course, it has metformin, it's coming in again, along with the synergistic effect of myoinositol for metabolic control, insulin sensitization, and to a large extent giving as an adjuvant or as a primary goal for ovulation induction. So all these therapies started will reduce the risk of GDM during pregnancy also. So my thing is yes for medication.
Excellent. That is why I brought up the sisters issue, and especially with her BMI. This is somebody who you would target with metformin, but please check vitamin B12 level before, because many people who get side effects with metformin have deficiency of B12, and if you just give them one shot of B12 injection, they are able to tolerate it much better. Now, okay, so she followed you. Dr. Neelam, उसने बोला मैं पूरा डाइट किया, मैं एक्सरसाइज किया, फिर भी प्रेगनेंसी नहीं हुआ. अभी what next?
So we have to see if she is a good candidate for ovulation induction and start with ovulation induction. Optimization has already been done, so we can see primary therapy, maybe letrozole is preferred now. We would go to that for the monofollicular growth as compared to the clomiphene, because clomiphene negative effect on the endometrium will also be negated. We will see her, of course, ultrasound has been done and rest of all parameters have been ruled out, adnexal masses or everything. The endometrium is good. So when ovulation induction is planned with the adjuvants, maybe a little bit more aggressive monitoring, follicular monitoring with the Doppler to check the peak systolic velocity, give a trigger at the right time, and maybe plan relation or add an IUI if she has tried enough naturally.
Yes, so we'll take that one step at a time. So we all know letrozole is safe. And when you compare to clomiphene, one point I just want to say this: time to pregnancy. You know, the patients who come to you, they are not going to give you 1 year or 2 years time. There is a very critical concept of time to pregnancy. So letrozole has been published in studies to reduce that time to pregnancy, and possibly that would be one of my favorite reasons why you would go for letrozole. We all know congenital anomaly ka risk nahi hai. So, my dear panelists, she now got fed up after 6 months, and she said, I will go to an alternative medicine or maybe some Ayurvedic or another doctor. And there she took 100 milligram clomiphene and got OHSS. Now she came back to you, ki I ended up in complication. Now what will you do? Somebody who has had OHSS on clomiphene, what can you do? Decrease the dose, metformin, letrozole, or LOD?
You would want me to take it?
Anyone. Yes, sure.
Okay, so if we have to first see if this OHSS is managed now, or we have to manage this OHSS.
No, OHSS is managed. I'm saying that now she has said that I made a mistake in switching doctor. I'm coming back to you. Now you tell me what to do. See, she has not taken letrozole. She went to an alternate doctor, took 100 milligram clomiphene and developed OHSS. So what to do for these patients who develop OHSS with 100 milligram clomiphene?
You can just switch to letrozole in such case if she has not taken letrozole previously, which is a safer option. And to prevent OHSS, we can add metformin if she has not taken metformin earlier. So we can add metformin and letrozole to prevent OHSS and go with the...
Yes, so I'm sure you have read that there are some studies which are published, and especially this Cochrane paper is very popular, that OHSS rates have been found to be similar with letrozole or clomiphene citrate. The only thing that is really effective in meta-analysis is metformin co-treatment. So I agree with you about metformin co-treatment. Now about laparoscopic ovarian drilling. Just a word about each of you. When was the last time that you have done laparoscopic ovarian drilling?
We never did.
We
10
have
years
done
back.
it in very few cases. Like last, I think it was done maybe some 8 months back, but that patient had AMH of more than 18, and she was a obese patient with androgenic features. So we had to do it because we had tried metformin, we had given her letrozole, but the follicles were just not coming up. So that time we did ovarian drilling for that patient, but not usually done, not a very preferred treatment now at present with other treatment modalities available.
I agree. So now what happened was that you decided, okay, I will give clomiphene 50 milligram. Now you did ultrasound and there is no follicle. On day 12 to day 15, there is no dominant follicle with clomiphene. So now will you increase the dose of clomiphene, add metformin, give gonadotropins or letrozole or clomiphene or letrozole? What will you do now? So this is a tricky balance between OHSS and no follicle.
I personally prefer to first of all, I
To
have
start
stopped
with switching to gonadotropin would be better.
Even though I increase the dose of clomiphene and I add metformin in such cases. Sometimes I have seen when you add clomiphene and just continue the cycle, one or two follicles, they come up by the same dose. I'll not increase the dose of clomiphene. I'll just add it with metformin. Sometimes it works, sometimes it doesn't. Sometimes we have to eventually
But
cancel.
if we are not talking about the same patient, if the other
No,
patient, we can see.
it is one of my patients. In fact, she ultimately ended up with IVF
Yeah, ma'am.
and has 3 babies
Yes,
born. She
she is
developed
not the
triplets.
same
She got
one, na?
triplets.
The
No,
one
no,
you were
it
talking
is
before. It is
this is
if it
the
is a new
same
case, then
patient. No, it is the same
okay.
patient. This is my actual patient who finally ended up in IVF with me, has delivered triplets,
That is what I was
healthy
Ma'am,
at 36
going to
weeks.
say, madam.
So,
So here,
yes,
if we are
ma'am,
looking at
for me, gonadotropins would be a choice
so
rather than beating the bush over clovefin.
But ma'am,
but madam,
adding
my
gonadotropins in ovulation induction, not doing anything other than that, then there's no point of giving gonadotropin.
Yes, I agree with Dr. Namrata also that if we are looking at a FSH window, that is when the follicles get recruited, even if the patient has given gonadotropins or clomiphene citrate, if the patient's recruitment is multifollicular and it is not giving, even on 100 milligram clomiphene, if she is developing OHSS, gonadotropin will also shoot the window. We might still have to look at OHSS or maybe conversion of an IUI cycle to an IVF in that regard. So this patient is higher preponderance towards not having a monofollicular growth.
yes, correct. So in this case, what I searched in the literature was you have multiple options. You can do all these, different protocols with letrozole, or you can have a dual CC, like 50 milligram of CC and 2.5 letrozole, because you want to be somewhere in between. These are for the tricky cases where you don't want 100 milligram of clomiphene, but you want something more than 50. So viable option would be add 2.5 milligram of letrozole, and ovulation is significantly more, but live birth rate is the same, and no twin or serious problem occurred. And just a word about gonadotropin, because you mentioned, just tell me which one are you using in PCOS patient? Are you using REC FSH or urinary HMG? What are you doing? Urinary HMG for Niharika?
Recombinant.
Recombinant for Dr. Neelam?
No, I am using HMGs. It is equally effective. Both are equally effective.
HMG is first preference always. Then sometimes we may need to use recombinant also. FSH.
Yes,
Few
so
cases.
that is what a lot of meta-analysis have said. But there is one thing that you can check LH on day 2, because especially she has been using pills for long. So LH, if it's less than 1, you can go for HMG. If it's more than 1, then it is your choice whether you use recombinant FSH or HMG. However, effect is same. Now she decided to go for IVF because she didn't want to continue because it was just she has already become 32 now. So in IVF, our law says to avoid OHSs. So what do you all do for protocol? Is anybody using agonist or everybody is going for antagonist?
Antag.
Protocol. Antag? Okay, so it is 100% consensus that she should have antagonist protocol, which is also the literature review, where you have not only the protocol but comparison of ovulation rate, pregnancy rate, OHSS rate, and prevention of OHSS. Of course, there are all these protocols that you should individualize the dose, give metformin, coasting, and cabergoline. And this is the La Marcia model. I mentioned this because it's very important now to avoid OHS. I cannot emphasize because in the law it is mentioned. So now she delivered, as I said, triplets, and all the three babies are doing really well. So now we come to the second case. 43-year-old lost her 10-year-old son in an accident, wants to get conceived with her own eggs, AFC less than 5, AMH 0.4. Please give me a short advice. What would you do? Androgen, DHEA, protocol? What is your strategy for such patients?
So, actually, madam, doing an androgen and DHA, I believe in a very practical approach of starting her for an IVF for herself oocytes. And we can go for a double pooling of the eggs. And depending on those embryos that we accumulate, we can definitely go for a herself banked embryo and going for a transfer. And if she requires, and if we have a good set of good quality embryo, we can do an NIPGS or a PGS depending on that. So I
Yeah.
don't believe in wasting time in giving her androgen for another 3 months and then asking her to come back. So I
Yeah,
think
she's 43-year-old already. So, yeah. So better than giving DHEA, I would have tried for testosterone gel at it takes lesser time. The other important thing in this female, as we know the concept about the oocyte, the number is less, but what about the quality? I should also counsel her if egg pooling and the embryo quality is not good, we may have to go for donor also. But I will counsel it at first, but definitely prefer the self cycle and egg pooling.
So I would want to add here.
Yes, please.
Madam, as Dr. Niharika and the other co-panelists have mentioned, these supplements are must. But along with that, while starting the cycle, I have little high threshold for doing PGT. So rather than that, what Dr. Niharika said, pooling of the embryos, in that only thing which I say is about you need at least 7-8 good quality embryos for getting a euploid embryo out of these embryos, because with age the number of euploid embryos will reduce, the percentage will reduce, and that is where the pooling will work. And another point which I will add to this pooling is sometimes amongst all the adjuvants, I have personally found growth hormone supplementation in the first cycle gives a little better embryos in the second cycle. So that is where our clinical experience comes in.
Very nice. So, just to go over what all I was showing was that this is the group 4 Poseidon. And as per Poseidon, you can use both testosterone gel and DHEA. In fact, they encourage the use of DHEA. They say you can use agonist or antagonist protocol, both. You can use estrogen priming. You can use OC pills also. So in this, you must follow the higher protocol. What is a higher protocol? Give an early trigger. Sometimes you think trigger today, tomorrow, so you give an early trigger. And luteal phase, you can do estrogen priming, which means start estradiol valerate from the day 14, or that is from day 16, 17, means from the luteal phase, and progesterone for withdrawal bleeding. There's a higher chance of getting synchronized follicles. If you're going to use the pill, make sure you have minimum washout of 5 days, at least 6 to 7 days washout. And this is the estrogen priming. Then you have this delayed start protocols also, and this is Niharika, your protocol where you transdermal, testosterone. Somebody else had mentioned, I think, where you have
Yes, ma'am.
androgel. You had mentioned, yeah,
Yes, ma'am.
25 milligram every alternate day or 12.5 milligram per day, and in the previous cycle you can also use letrozole, HCG, and do cycle control and double stimulation, as you all have mentioned, that you can get 2 waves of follicular recruitment and the eggs are equally competent. So now let's move on. And just to mention one thing, I practice in Haryana also. And in Haryana, if you have a woman who is already having a female child and like going for an IVF again, we are not allowed to do such cases unless you don't get permission from the government. So the rules have become really strict like this, because this was a patient from Haryana, and her son died, and of course we don't promise any sex or anything, but she just wanted IVF just to take a chance, but did not get permission. I mean, till now the application is just pending. So now let's move on to the next case. A 37-year-old patient, infertility, endometriosis, pelvic adhesions, now regular menstrual cycle. So she did 2 times IVF. Teratospermia for her husband. First, endometrium was very thin, thinner than 6 millimeter, but she had her own time commitment, could not wait. She did transfer negative. Second time, 5.9 millimeters. Endometrium ET was not done and embryos were cryopreserved. So, what is your assessment about endometrium? आप अपना assessment, like at what time will you do transfer? How much is thin for you? For each one of you.
0.8 is
Practically
7
8.
mm is thin. Less
But
than 7 mm is
but
thin endometrium.
Yeah.
and if it is
For
even
optimum, we say 8.
8, yeah.
Do you distinguish between fresh and frozen transfer, or you are all doing only frozen transfers?
All frozen transfers.
No, in fresh embryo transfer, if with a good
98%.
stimulation, you have higher level of estradiol. So I would take 8 mm as cutoff for the fresh embryo transfer, and that is where the results are found to be better. In HRT, however, we see little bit compacting of the endometrium. But usually, if by 9-10 days or something, if you have a good more than 8 mm endometrium, it's a very good endometrium.
It's a good.
But cutoff for HRT cycle is 7 mm.
7 we take HRT.
Right. So this was a huge trial, 40,000 embryo transfers, and I think this is in general accepted now that between 7 and 8 millimeters is, as Dr. Neelam has rightly mentioned. Personally, I am using 8 millimeters. Between 8 to 12 millimeters, we get good results. So this is the live birth rate versus the endometrial thickness, and it is definitely different between fresh versus frozen, because pregnancy outcomes is said to be better in frozen embryo as compared to fresh, especially in those patients who have thin endometrium. The likelihood of endometrium more than 8 millimeters varies with age. So it depends on the age of the patients, but there is nothing like no, pregnancy is not possible below 7, because we all have patients who have endometrium between 4 to 6 millimeters, because it is not the sole criteria. There are other criteria like the pattern of the endometrium, the estradiol level, and the vascularity. Correct. So,
Right.
what are the reasons that you find in your patients that endometrium is thin? What have you seen most commonly?
basically endometritis.
In Uttar Pradesh, where I'm practicing in Varanasi, here the main cause is they just get DNC done. Like for patient fertile, they'll just get a DNC done at some local place, some ASHA worker, some midwife will just get like DNC safai kara lo and pregnancy aa jayegi. So this destroys the basal endometrium. So this is one of the very big causes. Tuberculosis is one of the very big causes of thin endometrium in this part of
Yeah, same
Uttar Pradesh.
same in my state. Because of genital tuberculosis, the endometrium is thin and sometimes it's very difficult to
And
work on that.
one more reason is like if sometimes they have septic abortion and it will just destroy the endometrium. So these are few very common reasons of thin endometrium here. Yeah.
Very true, yes. In fact, I'm struggling with a surrogate case where endometrium was fine initially. I mean, I did her ultrasound. I think it was a menstrual ultrasound, day 2. And she got all the permissions after 6 months. Now she has come. Now endometrium is not growing. And I did hysteroscopy and I found products of conception inside. So, you know, it is... I completely agree that infections are one of the biggest causes that we are seeing. And now I've become really alert. So when I approve a patient for surrogacy, I've stopped doing day 2 ultrasound. In fact, I'm doing day 14, day 16 ultrasound to make sure that I see a thick endometrium before I send the application through. So now iatrogenic, as you mentioned rightly, is one of the most common factors also. Previous surgery inside the uterus, indiscriminate use of maybe medications like clomiphene, which desensitize receptors and have a strong anti-estrogenic effect. And of course, there are some idiopathic cases where despite everything, you cannot diagnose. And the main problem we know with thin endometrium is impedance with a high blood flow, epithelial growth, reduced VEGF vascular. So now what happened to my patient was that we tried 2 natural cycle, 2 HRT cycle, ovulation cycle with letrozole, but endometrial thickness did not exceed. So finally, I went for a tamoxifen cycle. Now, in these kind of patients, what first, please tell me about estradiol. That how much estradiol you use, what preparation you use, how much dose you use, and what are your recommendations for thin endometrium in terms of estradiol?
Maximum dose, 12 milligram.
Correct.
And yeah, but mostly I use Valerate. And sometimes it can take 20 days, more than 20 days, 25 days for the endometrium to grow.
Right. Anybody else? Are you using gel,
So
estrogen gel?
I'm using estradiol hemihydrate because of the just liver, because it is not yet recommended, but mostly hemihydrate all valerate. I go on the incremental doses of estrogen.
Yeah.
That is how the natural follicle will grow. So this is how we get the, and we can reach to maximum 12 milligram.
12 milligram.
We can add some estradiol tablet, effervescent tablets or gel, but I'm not using them much. So I wouldn't comment about it.
Okay. So when you talk about incremental, Dr. Neelam, you start with 4 milligram and then you put it up, or you start with 6. How much would you start with?
I would start with 4 milligram. It depends on different situations, but usually with 4 milligram for 3 days at least I continue. I don't switch immediately, 3 to 4 days. And after that, we switch add 1 tablet, continue that for another 4 days, do in between scanning, and then we can assess what is the, if the endometrium is becoming static or if it is showing a progressive growth, because that is where the implantation rates would matter. If it is long time static, if it is crossing 15 days, and if it is static, we sometimes miss the implantation window.
So what we do in our centers in some cycles, we start from day 2 to day 5. We'll start with 2 mg twice a day. And then from the 6th day till the 10th day, we do thrice a day. And if still it is less than 7 or our target it is less than 8, we will add on, if possible, we add on those vaginal, especially those gels, we add on those gels. That are 2 measures either twice a day. That's how we do that.
Okay, so what I learned in the last conference, in fact, Niharika from Lucknow only, estrogen vaginally. I want to ask if any one of you, the same estradiol valerate or hemihydrate which we use orally, is anybody using it vaginally? No.
No.
So this was presented And this is really phenomenal results. I mean, I'm using it myself, and my presentation, I have not put it up because I did not do a literature search, but I heard it in the conference and I've started using, and the results are outstanding. So if you have a patient of thin endometrium, I would recommend try both the same, whether it is valerate or hemihydrate, whichever one you are using, a 2 milligram tablet, use it twice a day vaginally, and you can get good results with that. So overall,
Can I add,
believe.
Shivani?
Huh?
I also started using for last 6 months vaginally. It
Huh.
is very good result.
Yes, I see. So at least the person who is listening, they will have one benefit in their practice, that you start using estrogen vaginally and you'll get good endometrium.
Make sure that tablet, which I'm not telling any brand particularly, make sure that some tablets are not easily dissolvable. So make sure the tablet which you give is dissolved. Some has got a
Exactly.
capsule. That is the one you have to see before.
Exactly.
Dr. Shivani, even I am using hemihydrate tablets in through vaginal route, and it gives excellent results.
Yes.
That's good.
Dr. Anu, thank you. So now quickly, because I have to very quickly, HCG, has anybody used HCG, and what is the dosing protocol? So what I found was daily use 150. So the one that you get like 2000 units, you have to really dilute it 10 times and use daily 150 for 7 days, and that can also help. GnRH agonist is supposed to help, especially after ovum pickup. This is like a meta-analysis where you have estradiol with HCG and with GnRH agonist. And the protocol, Dr. Neelam, you suggested this is used by Chen et al. 4 to 8 to 12, although there is no evidence that you increase the dose or use a single dose, both the results are supposed to be the same. Now, I want to know from you, anybody is using sildenafil, pentoxifylline, aspirin? Anyone has used any one of these three?
Yes.
Yes, aspirin, pentoxifylline, and some.
Aspirin, sildenafil, pentoxifylline.
I think everyone has.
all.
Yeah.
Very true. So the sildenafil increases
Improves the
thickness
blood
and blood
flow.
flow.
Blood flow.
Exactly. And what about aspirin? What is the dose you are using? 75 or 150?
75.
75.
If obese,
150.
put down to 150.
And if
BMI is more than 30 or 29.
Yes, so you can use 75 or 150. Sometimes I find that at the time of embryo transfer with 150, I get little bleeding. So that is why I have switched over from 150 to 75. At 75, I don't experience that because every time the embryologist, ma'am, blood hai, catheter mein blood hai. So that is the thing that I found. It is only at the external loss, and really it may not matter. But 75 is my personal preference. Now, what about tocopherol and pentoxifylline? Are you using tocopherol, vitamin E?
I think
No, I have
Nobody is using.
Vitamin
Okay, so
E in general for persons' general health, and if we feel that they have mild endometriosis, adenomyosis, or like how we want, some patients do respond to vitamin E very well. It's a very powerful antioxidant, as in male infertility also.
very beautifully said. It is a very strong antioxidant, and the correct dose is almost 800 milligrams a day if you're using it for endometrial preparation. And if you see literature published, guidelines say that only and only vitamin E works. Sildenafil doesn't have effect. Aspirin, no. Pentoxifylline, no. The only beneficial effect literature has published is vitamin E, and that also in a dose of 800 milligram per day. And so this is again meta-analysis of sildenafil, aspirin, pentoxifylline, and something else called neuromuscular stimulation. I mean, we are not using any of that. So ultimately, what happened in this patient was that I will show you in the diagram. So 5 days of tamoxifen, and then we had 6.1 endometrium ovulation, and after ovulation, embryo transfer was done, and 3 embryos transferred, and she had a positive pregnancy. So what about GCSF? Are you using GCSF or have you given up on GCSF?
Given up on GCSF, honestly.
Given up on GCSF.
Right. So even in my practice, I'm hardly using GCSF because somehow the initial studies which were promising excellent results, that really did not translate. And we have so many meta-analysis published of GCSF with varying different protocols, day 7, 2 to 9 days before ET, day 14, day 10, day 12, day 13. So you can see all the meta-analysis. Tamoxifen, has anybody used tamoxifen?
Yes.
Yes.
How was your experience?
Sometimes when it doesn't work, Temox also not work.
Sometimes when nothing works, then we go to tamoxifen.
Yeah, so I would like to suggest that it is definitely something that you should consider because I have had success with it. So definitely I would also recommend that you consider. Now, what about surgical therapy, PRP and bone marrow stem cells? How many of you are doing stem cells or PRP?
We are doing
Not.
PRP.
Yeah, PRP we are doing, but
with PRP we are doing with subendometrial installation
injection.
Injection of PRP.
So when I'll just say when we started PRP, we started I think 2015. I did some like papers in Mumbai also for intrauterine installation of PRP, and I felt it will be very good and very useful. I'm just discussing this experience, and slowly we kept on getting answers to what PRP is helping, but intrauterine installation was not giving that great results. But after that, when we started doing subendometrial PRP, with maybe sometimes what we can do is give GCSF injections to derive the bone marrow, say peripheral blood cells. Pull your platelet and plasma, and then do the PRP processing and put it subendometrially. In very difficult cases, when we have done everything else, infections rule out and adhesolysis, everything else, then this can sometimes work where there is a very poor endometry.
Very good. So proper selection of case is important. Only then you are going to get the benefit. Dr. Neelam very nicely stated. And for PRP, I'm using hysteroscopy. And just for those people, now who are facing problem of backflow with the needle, at the last conference I attended now indoor, so I found out there are new PRP needles because we were using 3-way. So now you have needles so that the backflow does not come. And I am doing a lot of stem cell because I had all these patients of surrogacy who could not do surrogacy. So I started doing a lot of stem cell treatment, and it has phenomenal
Stem cell from the blood?
From autologous bone marrow derived cells. Dr. Prabhu Mishra used to come to us before, now he doesn't. So bone marrow derived cells, phenomenal results. You will not believe a uterus which is as small as the laparoscopy instrument forceps, like hardly 2 centimeter, 2.5 centimeter, no endometrium. These are the patients who are giving birth now. So bone marrow derived cells has definitely had some really very good beneficial effect. And I want to now, thank all my panelists and thank the organizers also for giving me this very wonderful opportunity. We have overshot our time, but I'm hopeful that you all got useful take-home messages. Thank you.
Thank you, madam. Fantastic panel. Fantastic panel.
Yeah, same here. Thank you so much, ma'am.
Thank you, Shivani, for such a wonderful information, insight, honest intravaginal estradiol, and dose of the Evion, vitamin 800 per day. So very nice insight. Congratulations to all the panelists and Shivani and our convener, Dr. Anu and Dr. Fesi. Thank you so much, Anu, for the invite.
Thank you. Most
Thank you,
welcome,
dear.
ma'am.
Thank you so much.
Dr. Shivani, it was a
Thank you, ma'am.
wonderful panel, and all panelists were too good.
Thank you, ma'am.
Thank you, Anu, for this thing, calling us and giving us this thing. And Shivani, it was really a nice panel. Yeah, we really
Thank you, Prerna,
enjoyed.
ma'am.
Yeah. Thank
Thank
you,
you, Dr.
Neelam.
Prerna, for being here till the
Hi,
end.
Yeah.
Prerna.
Dr. Tarini
Yeah.
ma'am, and all
You
the
were,
delegates,
Yeah.
thank you to all the delegates. Because of you, we have made the program, we can make the program successful.
Thank you.
no,
We always feel so happy. So,
yeah. We like with Shivani, I face one problem. I think we should look at her or we should listen to her. So that's the issue. She looks every time she looks so pretty and so beautiful. Yeah, Shivani, God bless you.
It was so nice of you. Thank you.
Yeah. Okay.
Hi,
Bye,
Prerna.
everyone.
Okay,
Hi.
good night.
How are you?
I'm fine. How are you?
Good.
Good.
Hi,
So
Neelam.
we should
Neelam is,
say thank you to Anu for bringing us together
yeah.
and getting us.
Yeah.
Yeah, Tarini. How are you doing, Tarini? Dr.
so
Tarini?
my
Good.
pleasure only.
I'm really happy to see you here.
Yeah.
You, Neelam, Anu,
I know.
everyone.
So we had a good time in ISAR embryology.
Yeah.
Yeah.
I know. Let's keep coming together again and again.
Yes.
And
Thank you.
yeah. And invite you to all to my place. Yeah.
Definitely. We would love
Yeah.
to come.
Yeah. Bye, everyone. Bye. Good night.
Bye,
Anu,
everyone.
may I give the closing
Bye.
remarks?
Happy
Thank you,
Navratra
Noti
and good night.
Happy Navratri, yes.
Navratra to
Jai
everyone.
Mata Di. Happy Navratri
Jai
to
Mata
everyone.
Di.
Yes, Jai Mata Di.
Jai Mata Di. Jai Jagdamba. Good. Shivani, nice.
Thank you.
Yeah, thanks to all. Thanks to all
Thanks.
panel. Yeah, Shruti, you can.
Yes, sir. Thank you. So, on behalf of entire UNS team as well, I would like to thank all of you for being present for this 14th ISAR Fertility Catalyst webinar. Your presence truly made this event more insightful and more impactful. Obviously, thank to our chief guest and guest of honor, Dr. Reshma Pai ma'am, Dr. Neena Malhotra ma'am, and both of our speakers as well as our moderator for the panel discussion for such an insightful and impactful session. Also, thanks to the Central ISAR team, Dr. Amit Patki sir, Dr. Asha Bakshi ma'am, Dr. Anu ma'am, and Dr. Fesi sir for their continued support and for this collaboration as well. Thank you once again, not taking much of your time. Good night, everyone.
So thank you, Team UNS.
Thank you,
So
ma'am.
we'll meet in October for our next CME.
Yes, ma'am.
Definitely, ma'am. Definitely.
Okay. So bye. Good night, everyone.
Bye. Good night.
Good night.
Bye.
So stop the recording. Jignesh,
Recording
thank you very
stopped.
much. You can stop the recording. Okay. Yeah, live also you can stop.